Hey class, this is Professor Baston, and today I want to demonstrate how to do a needle thoracentesis or a chest decompression. So the indications for a needle decompression or needle thoracentesis is to relieve the pressure associated with a tension pneumothorax. Keep in mind that a tension pneumothorax can occur from a simple pneumothorax that is either left untreated or missed, or most commonly, a tension pneumothorax occurs when the integrity of the chest wall has been compromised by some form of penetrating trauma, either a gunshot wound or a knife wound. So the way a tension pneumothorax forms is with each inspiration, air is allowed to enter the pleural cavity through the opening in the chest wall. If someone's on positive pressure ventilation, say they've been intubated and they're on a ventilator, this can accelerate the development of a tension pneumothorax. With each exhalation, though, air is not allowed to exit the chest, the pleural cavity, and the air accumulates within that pleural cavity. So air goes in, but no air comes out. A tension pneumothorax results when excessive amounts of air is allowed to accumulate in the pleural cavity, resulting in an increase in the interthoracic pressure, a compression of the lung on the affected side, and compression of the heart, great vessels that are found in the mediastinum. So recognition of a tension pneumothorax, keep in mind this is a clinical diagnosis and is based on mechanism and symptoms. X-rays are not needed to make the diagnosis. Symptoms are progressive and related to the degree of compression on the heart, lung, and great vessel. Early signs, you're going to see someone who has an injury to the chest wall. When you listen to the chest, if you do, you're going to have decreased or absent breath sounds on the affected side. If you should percuss the chest, you're going to have hyperresonance to percussion, and the patient's going to have difficulty breathing. More progressive signs, as the pleural cavity fills with air, the lung is compromised and now compromising the heart, reducing cardiac output. You're going to see a patient who is hypotensive, tachycardic, tachypnic, cyanotic. You may palpate subcutaneous emphysema up around the collarbone, and they're going to be short of breath. Late findings are tracheal deviation. If you ask any PA student or medical student what is the signs of a tension pneumothorax, the first thing they always say is tracheal deviation. But tracheal deviation is a late sign. If you think about that, the trachea is attached to the mediastinum is firmly attached to the mediastinum. It takes a lot of force to push that trachea to the other side. So if you see tracheal deviation, patients are on it's a late finding of a tension pneumothorax. So how do we manage a tension pneumothorax? One of the first things you want to do is seal the opening in the chest wall with a non-occlusive dressing on 3 sides. Always be sure to check the patient's back, because the back can be the exit wound or it can be the entrance wound. Again, keep in mind this is a clinical diagnosis and you're basing this upon the mechanism as well as your physical findings. If you have time, prep the chest wall. Next thing is to identify your landmarks. The primary landmark is the second and third intercostal space at the midclavicular line, but you can also use the fourth and fifth intercostal space at the midclavicular line. There are commercially acquired chest decompression needles out there, and this is what one looks like, very long and very big. Or if you don't have these available, you want to use a 14 to 16 gauge angiocath at least 1 3/4 inches in length. If someone has a lot of adipose tissue or has a very muscular chest, you may need to get a longer needle in order to get down to the pleural cavity. Once you've identified your landmarks, it's a very easy procedure. You identify where you're going to be at. So second, third intercostal space, midclavicular line is right here. And you just insert your needle straight down. You want to make sure you go over top of the third rib, because if you go closer to the second rib, you can hit the vessels and the nerves. As you enter the chest, it's going to take a little bit of force to push you down, but as you enter the chest and enter that air-filled pleural cavity, you should hear a rush of air come out, okay? Once you hear the rush of air come out, you remove your needle and leave the catheter in place. An alternative way of doing this is if you're in a noisy area where you feel like you might not hear the rush of air come out, you can take a 10 cc syringe and fill it with about 5 cc's of water, attach it to the bottom of your needle, and as you go through and enter the pleural cavity, Watch for bubbles in the barrel of your syringe. And again, the same thing applies. Once you're there, once you see bubbles, the syringe comes off, needle comes out, and you leave your catheter in place to let the air drain off. This is just a temporizing procedure. Once you do a needle decompression, you need to move immediately to a tube thoracotomy or a chest tube for more definitive care. Some complications of a needle thoracentesis, and this does happen. You have a patient who you think has a tension pneumothorax, and it isn't. You're going to cause a pneumothorax. That's just kind of one of those things it happens. You may cause a pulmonary contusion, a lung laceration, and as always, infection at the insertion site. Very easy procedure to do, but it is a life-saving procedure that's done for a tension pneumothorax. That's all. Thanks for your attention.